Welcome to this webinar. It's an honor and a privilege to introduce Professor Benedikt Schoser. He is a trained neurologist, neurophysiologist, neurointensivist, palliative care physician, and muscle pathologist. Professor Schoser is Professor of Neurology, Senior Consultant Neurology and Co-Chair of the Friedrich Bauer Institute at the Department of Neurology, Ludwig-Maximilians-University, Munich in Germany. His special interests are multisystemic neuromuscular disorders, translational research, and therapy. Professor Schoser has authored and co-authored more than 350 peer-reviewed articles with a focus on diagnosis and translational trials, and he has been responsible for the pre-Congress teaching course at the annual Congress of the World Muscle Society for many years, and he is Associate Editor of Neuromuscular Disorders. It's clear that Professor Schoser is a big name in the field. He is co-founder and chair of the European Pompe Consortium, and in this capacity totally involved in development of novel therapies for patients with Pompe disease. We are extremely happy that he is willing to give a presentation entitled Pompe Disease, Current Treatment and Future Prospects. Before I give the floor to Professor Schoser, I would like to encourage you to raise questions which can be posted in the chat, and there is ample time after the presentation to discuss your questions. Benedikt, the floor is yours.
Thank you, Marianne. I will share my screen. I've done the presentation mode. Hopefully that's all fine now. Hope you can hear me well. So thanks indeed for the too kind introduction. Dear colleagues, it's a pleasure to talk about one of my close to the heart diseases, and let me start. It's a very interesting name. So why is it called Pompe disease? So normally there are names to different things, and only a few things we still address with names. But Pompe disease, it's really the given name by the Dutch internal medicine guy who first discovered really Pompe disease in a child with a cardiomyopathy. And of course, as usual in these things, there are others around the globe who also have same experience made in that period. So therefore, there's a guy called Bischoff and another one, Pucha. They all describe very similar, simultaneous, in a way, what we today call Pompe disease, cardiomyopathy, loaded by glycogen in the cell. And by this, I will start. And a very sad story is this man, Mr. Pompe, was really killed by German Nazis at the year 1945. And so therefore, very late in the end of the Second World War, and that's really a pain in the ass still till today. Anyhow, here are my conflicts of interest. You have time to read them. Of course, I also worked in the field of Pompe disease with pharma companies, and I still do. We want to continue, and so therefore here this is. So Pompe disease is an autosomal recessive severe metabolic disorder with a progressive neuromuscular degeneration. It's a monogenic disorder. We know till now more than 500 variants in the GAA gene that results in a deficiency of the GAA, an enzyme that is critical for the metabolism of glycogen stored in lysosomes. And you have a very good refer bank for this, for the different gene variants that is in one of the absolutely world-class lead centers in Rotterdam at the Erasmus University, a long time led by Hans van der Bloch, who really did here groundwork for many, many years, just retired this year, but of course in succeeded. Very good people like Nadine van der Beek, who continues to work on this. The glycogen accumulation in the cellular occurs in then also the muscle tissue and leads to organ failure. And here in the diagram in the stretch, you see it clearly. So there's normal lysosome and myofibril content, and if there are stored glycogen, then you have really a loss of myofibers. And on top of this all storage, there's also an autophagic process imposed into this situation. So what happens, and how can we then understand that we have a very severe infantile onset form and a graduate different type of a late onset form that starts after the year of 1. So in the infants, we have absolutely no or less than 1% residual GA activity, while we have in the LOPDs between 1 and 25% of residual GA enzyme activity. And the heterogeneous carriers stay in about 50% of normal GA, normally, therefore, they are unaffected. We see that signs of Pompe disease emerge when the GA activity is below 25%. That's something we know from a very nice paper, one of the final paper of Arnold Reuser, another icon in the field of Pompe disease, published by Nino in 2021. The glycogen accumulation and the cellular damage, that's really why we have this muscular component in that, but it's definitely more than this. So what is the incidence all over the world? So there was always a rather rough number between 1 in 40,000 to up to 1 in 200,000. And we looked last year for really more precise prevalence in the different countries. It's still, if we go for the newborn screening that is now available in some of the US countries, higher than we really considered previously, but also there's differences country-wise. In Europe, it might be a bit lower. And if you go to countries like Finland or even to Sweden, then you have hardly any Pompe disease. Normally, they are really high in recessive disorders, but here they stay out. There is no one ever turned here. If you compare to France and Italy, there you have the regular European number, so 1 in 70,000. And for IOPD, it's something about 1 to 82,000. That's normal. But if you look for US, it's really a high variability of these different diseases. So therefore, it might be rarer in some places and more frequent in others. That's something we need to learn. It's not uniform, and that's very important. So we have a severe progressive disorder leading to death in early childhood. That's really the Pompe disease of the infants, more slowly progressive ambulatory and respiratory failure in the later onsets. We know that respiratory failure and cardiomyopathy are the leading cause for morbidity and mortality in the patients, and the manifestation may vary between patients throughout the disease and their life. And so it has historically been considered as primarily a muscle disorder, but we now know definitely it's much more than this. So the term really characterizing late onset was a skeletal muscle involvement, where we have fatigue, exercise intolerance, myalgia, respiratory insufficiency, and also muscle weakness and atrophy, and of course, a raised CK. That was the very classic signs and symptoms. But if we consider now the new picture, then of course this muscle stays the core, but we have nearly in all organs some involvement, and that can be on top in late onset patients. We know that quite a bit of gastrointestinal and urine tract involvement is there. We know that there can be also cardiac manifestations like a Wolff-Parkinson-White's heart rhythm disorder in some of the late onset Pompe patients. We know there are the cerebral vessels can be involved, consider like megadolicobacillaris and things like that. So there's quite a bit of different things they can add up. And as we learn from many of our pure muscle diseases, they have also multisystemic involvement because the enzyme is everywhere. So the overall burden of this disease and the progression, so we know that 80% are affected by proximal weakness, 50% need mobility devices and wheelchairs, 50% need respiratory supportive devices, 30% have really difficulties with ambulating, limited gross and fine motor skills, and we have something about 20% early mortality in our patients. So that's there, and that's at the base of this disease. So therefore, it's a severe disease in the end. And what can we do? So what was our classic strategy for the screening? Of course, you have the clinical phenotype, and then normally you went up doing an EMG. That's hardly done in those days, but still we have here a rather mixed pattern. We can go for muscle MRI and of course function tests, but then the easy things what you can do is just stain with PAS your peripheral blood, and then you see here this vacuolated, pass positive filled vacuole gives you a first rise. That was the very classic test. And of course, today we go for the gold standard. That's the analytic of the gene that stays. And only in a few cases, we do still use the muscle biopsy as our primary diagnostic thought. And for the immunology, we do now the dry blood spot testing. That is really something core and best from fibroblasts, but normally we do it out of the leukocytes, and that's also helpful. Of course, that's the standard for doing the diagnostic pathway, is a bit more complex. And you see one of the cornerstones in the diagnostic pathway is now a dry blood spot testing. And I recommend in each and every patient with an unclear limb girdle syndrome or a restrictive respiratory insufficiency, and also in asymptomatic hypercemia patients, go after your clinical examination also for a dry blood spot testing. That is very important. And of course, you need to really be sure that this is a Pompe case. Then you need to have the gene analysis. That is very important to stay with that. And if they don't have found really the Pompe mutation or just one at the beginning, go for GAA tissue analysis. That's next. And again, do recheck the GAA genetics, because sometimes there are big deletions. They are not covered well in the beginning of some of the gene analysis setups. So therefore, that is very important to have the dry blood spot test not neglected. We need it still. It's something that is very helpful. The good thing is this is a disease that is now since 2006 under a licensed drug. So it was one of the first rare diseases where we had really, after a first phase 3 study, a clear result that enzyme replacement treatment with that done with alpha-glucosidase alpha is helpful. That's the so-called LOTS trial. That was the first one that led to the myozyme licensing all over the world. Lumizyme called at that time in the US, but it's the same drug. And here you could definitely see that after a treatment period of 78 weeks, we had an improvement of 3.4 predicted % of the focal vital capacity, and also an increase of 20.12 meters in the 6-minute walking distance. You could say, well, what is this about? Lung function, I agree. So that's a big step, declining, and now have a stabilization or improvement. But what means 28 meters? 28 meters means that a patient can be independent, at least at home. And that's really, for quality of life aspects, a big step into the right direction. Then we came up with the second generation enzyme. So they've modified. One was the COMET trial. So here we used the alpha-glucosidase alpha, and on the other hand, the PROPEL trial. Here we used the sipa-glucosidase alpha and miglustat and compared this to standard of care, or in naive patients just under the new treatment. And here you can see in the COMET trial, the major outcome was another 2.43 or 30-meter improvement, and a 3.3% improvement, and a 13.6 meter. Both these aspects led to the licensing of these drugs just a few years ago. And if we look for the long-term outcomes in these here, first for the PROPEL trial, you see here for the naive patients or non-pretreated, the 6-minute walking test predicted and the forced vital capacity, you see there's still an increase, but it's not on a very high level. So if you look back in the preclinical settings, you would have expected a much more improvement. But still, we see even in those who were already formally treated, but also naive treated, that there is an increase. We had not really a super stable situation with a forced vital capacity, but we had really a very good motor function outcome for this. And here the 104 weeks data, very similar. You see there's still a difference between both, and it's not on the very high level, but still better than the former standard of care. That's why here we look for the COMET result, very similar curves. If you look at all of them, forced vital capacity, after 145 weeks in this setting here, you see there's still an improvement with those who are now on the new enzyme, and also the forced vital capacity stays stable here in this patient population. So it's a good second generation, of course, not a perfect one. We need more and more to come. And if you look for side effects, they are very similar. You see with Zipa and miglustat a bit more also on the GI side effects, but all what we know from myozyme, there's no surprise, nothing new really for us. We see here from the side effect screens in both the enzymes, both new enzymes. If we look for the real world data now, so that's a thing I did together with Nadine van der Beek. There you see, well, if we shift from the alglucosidase, the former standard of care myozyme, to AVA, and they were pre-treated, considered this already nearly 11 years, and they had, as a group level, really stayed rather stable. The lung function it also a little bit declined, and also the 6-minute walk declined. So therefore, there was a bit different situation, but consider also the numbers we had. So those were 29. And if you look for those who shifted, again, here in the second study, also here you see that previous, if they are treated less than 4 years, then we had a bit better improvement for the forced vital capacity and also for the 6-minute walk. So this, what we have currently in hand, calls that an earlier shift to the new second generation might be in a benefit for the patient. And of course, we consider currently that we don't continue giving myozyme in the most of the patients and switch them to one of the 2 new enzymes, and also a new naive patient, you would start with one of the new enzymes. There's no clear picture which one is the better one, but it's a shared decision, so you need to discuss with the patient what is really the consideration with both enzymes. As we did realize that this becomes a trouble, we started in 2023 and redid it already earlier, but there we thought we need to have an update of our guidance on the enzyme replacement treatment in Pompe disease. And I give you a brief summary. They're already published. You can read them in 2024 last year. They clearly give you some guidance. And the so-called triple S criteria, so for start, switching, and stopping the treatment, we first bring really up to your attention again that the patient should be symptomatic. So that was still for us a core. We should have some skeletal muscle weakness on the examination. We should have also respiratory muscle involvement that really can be clearly demonstrated by functional lung tests. That's very important. Of course, we agreed that supportive paraclitic signs like the muscle MRI is very helpful in that situation. And if we see there's substantial fat replacement, that this supports definitely the decision to start. And we thought, and that's, of course, an easy number, and it could be 10% or it could be 20, but we decided at that time we should have a fat fraction of 20% or more in at least 2 muscles. That is really considered as abnormal, because 20% is something you can see yourself if you look at a muscle MRI. All below 20 needs to be really stratified and done by a qualitative readout, and you can't just do it via looking with the eye on the muscle MRIs. That was one of the things there. And we also thought, well, we need to define something like a disease severity. So really, what is in that? And especially important for us was the definition of a minimal residual functional state. So this is definitely where we don't see that ERT will help if we start this in a bedridden patient with a medical research council grade less than 2, severe generalized muscle atrophy, ultrasound or muscle MRI shows and supports this. And we have also a maximal or minimal residual symptom lung function with a constant high CO2 level. That definitely is something where we would not consider to start ERT, because we don't see that any of the data we have in hands give a green light for this type of decision. Also, of course, comorbidities, that's important. And also there needs to be a commitment of the patient and the clinician that they come and let them monitor under this still very expensive treatment. And the new thing, the good thing was with the new enzymes, we have really now in all the European states included that they can be done in home infusions, but still under home infusion, they should be monitored. And that's very helpful that we still know what is ongoing with the patients and don't lose them in the thing. So switching can be considered if there is really no indication that skeletal muscle, respiratory, or muscle function has stabilized, and that a minimum of one of the enzymes is given for 12 months. So don't switch too early. So 12 months is a minimum, staying with one enzyme. And also you can consider it, but if there was a severe infusion-associated reaction, that could be also a part of a switching. But our new really element on this is that we already know this is not helpful. You need to do something else. There is a desensitization protocol in place, so you can read it. It was just the paper that came out in Journal of Neurology where we described this type of pathway. That is important. That's better than switching. And also, if we see then that the current insufficiency evidence is to inform with one of the enzymes is beneficial. So switching should be therefore be discussed really patient by patient and not just done. But in many places, it's already happening. So therefore, this is already a bit outdated in a way. But of course, if there's at least have a monitor visit for the first 3 months and then at least every 12 months, that's very important. And with all these new treatments, and I think that is something we really have to consider and also don't neglect in the advanced stages of the disease, we need also a palliative care plan. So advanced palliative care planning is important. But really stopping criteria, if we see that we have a bundle of really infusion-associated reactions that cannot really be covered. So there's really this chance with this desensitization protocol, perhaps that is in younger patients really needed, that we can continue with the ERT. We have a very few patients where we have high neutralizing anti-drug antibodies. That's rare, so that's good news here. Of course, in any case, if the patient wishes to stop, and if we definitely see after the first 2 years of treatment or switching that there's absolutely no change and still a decline, so that could really cause the discussion with the patient to discuss if we really continue or if we stop this type of treatment. Of course, end of life is a decision we're always, and we have still limited evidence for the continuation of AAT during the pregnancy and lactation. That's something else that needs to be discussed. With myosin, we have some experience. With the newer one, we have so far only limited evidence that this is easy, but still seems to be doable in many patients. So we also considered what could be the assessments and being here really easy, looking into the situations you can easily cover in all neuromuscular centers. So of course, for the skeletal muscle, we are interested if this is a wheelchair-bound patient, and especially what is permanently, that's if we can do less than 10 steps outside of the wheelchair. We want to have the 6-minute walking test. Unfortunately, we still need to do that at least once a year. It's our standard. We can't get rid of him. And other, please, time tests. So time up and go is a very good one that you can do here. And only optional, of course, the MRC grading and muscle MRI. For the pulmonary function, it's really interesting to have the forced vital capacity sitting and supine. Of course, we need to know ventilation, yes or no, non-invasive, invasive. And here, please, we need to have the numbers of hours. That is very important. MIP and MAP is optional. We know it pretty well. We have a very good instrument. That's the RPACT. That's a rush-built instrument on Pompe disease. Please use that. Easy going, easy good. On top, you need to do a fatigue severity scale. That is good. And also in many of the patients, there is pain a problem. So therefore, use the short, brief pain inventory. That's something that is very helpful for monitoring the disease. And that should be done at least every 6 to 12 months. That would be the adequate situation. 6 would be, well, desired, but we know reality will be 12 months, but that is something very good. And also look for co-diseases, the survival, and also what is really ongoing. What is the ERT duration? Is there a switch? Is there a stop? And then we have rather good information. So coming to the final part of my talk. So why is all this transformation from all the preclinical work into our clinical realities so tricky? Why is all this enzyme we give and all the tons of euros we spend, why is it not really a first-class outcome so far? It's a good outcome, but of course there's still a lot of room to improve. So one of the caveats we have is disease progression in Pompe disease under ERT remains significant. So this is, of course, a summary we did in 2021. So there was not included the new ERTs, but I can tell you if we would overlay with the new ERTs, it would look very similar. We have a very good period of the first 3, perhaps 5 years with our ERTs where we do good. Thereafter, there is more that is beyond just the enzyme. We know that autophagic buildup and things like that is really an element here we not address with our currently used treatments. So therefore, that is an important thing. So we know that there is really the sum score is going down, the forced vital capacity is going down, and also our 6-minute walking changes. The second, and that's in a way underlaid or mingled with what I said before, is that whatever we give from the first generation, we know it pretty well, but it seems unfortunately that the second generation ERT is not really doing much better, that only up to 1, perhaps 2% of the circulating GAA is really taken up by the skeletal and cardiac muscle. For the cardiac muscle, it might be okay. For the skeletal muscle, it's not enough because we know that the recombinant protein in the bloodstream is not always stable. Also, miglustat is here one of the helpers, so therefore that was really the innovative part in the Amicus trial we did there. But still, it did not work out much better than without miglustat. We know we have these high volume and time-consuming infusions, and that's every other week. We know there is an immune response in some of the patients. And still, the most caveat is that the biodistribution to the muscle is not 100%. Efficient, and autophagic buildup and also the glycogenic and glucophagic buildup is a topic we need to cover better in future. And to give finally you some examples why it is so tricky, I go back to the infantile onset patients. So here we have now for these infants now aged between 5 and up to 16 years, we see that what is not a topic in the adulthood, but in the infantile onset, we do not reach really the brain. And by this, if you look here from intelligence test scores in patients with classic infantile onset disease, you see there's a STEAM decline, there's a language problem, there's a problem with the tongue, with the articulation in these patients. And even if we go to the second study, here you see more clearly there's a progressive brain abnormalities and changes in the cognition in those patients. So therefore, we need to come up for the infants with new things that is really beyond what we have with the ERT, because the ERT protein, it's a huge protein. It's not trespassing the blood-brain barrier, so therefore the brain stays out. Still, the disease continues in this organ 100% in the infantile onset, and that's our reality we have to face. We need to do much better in the infantile onsets. So what are the new avenues for Pompe disease? Of course, I told you a bit about the first and second generation here, the red part of the left side. That's clear cut. We have the 3 licensed enzymes. There is now a start of the so-called substrate reduction treatment, first generation. Phase 1 is done. Phase 2 will come soon. So here is the consequence that we reduce glycogen itself in the beginning so that we don't need that much high enzyme. I think it will always stay a combination of substrate reduction and ERT in combination, but that's there. We have perhaps 3rd generation ERT. So one of the big players in the ground for muscle diseases is currently the transferrin receptor. We know that works well if you have a transferrin receptor linked to antisense oligos. That's used in our phase 1/2 trials for myotonic dystrophy and other diseases. And now, of course, there are companies coming up with this concept, linking the GAA to this receptor so that we improve the uptake into tissue. And that would open the door also, because you have this for the central nervous system as well, that we also can trespass to the central nervous system here and have this. And of course, then we have the classic EEV or lentivirus-driven gene therapies. There's different approaches depending on your promoter. You could do a liver-directed gene therapy using the liver as GAA pump. You could do a muscle-directed gene therapy, and also, but this is future topics, central nervous system-directed gene therapy. That would be really the thing we would need for the infants, definitely. Ex vivo, that's the lentivirus approach that is in an early phase, but I still think that this is also something very helpful, and we should really develop this further. So by this, I hope I can give you a little summary on what is ongoing in Pompe disease. We have 3 enzymes. There's a lot of things they help. Of course, they are not 100% helpers, but this is for rare disease something, well, that's really the higher ground. But in the end, definitely it's a super helpful tool, and new things will come, including next generation ERTs, gene therapy, and substrate reduction. Thank you.
Thank you very much, Benedikt, for a brilliant and comprehensive lecture. Let's see, and let's ask Elisabeth whether there are questions in the chat. Elisabeth? You are on mute. Your microphone is muted, Elisabeth. Well, in the meantime, perhaps I may raise...
Sorry, there's no question yet.
Okay, well, I have 1 or 2 questions.
Yep.
Benedikt, you showed... Oh, let's see, here is a question. What do you think about chaperone therapy from Sandrine P. or Pi that you did not mention in future avenues for the treatment of Pompes?
So chaperone treatment was in the beginning done. So there was really a trial that was stopped by Amicus very early. So that's 10 years ago. There was the idea that the chaperone could stabilize some of the mutations and by this improve the enzyme quality. We had here really some really severe side effects. There was really decline because the chaperone was overdosed in a way from what we had. So therefore, this study was stopped. And in a way, this concept was redone using now miglustat as an enzyme stabilizer. So really, miglustat is here used at the day of infusion of the enzyme to stabilize in the bloodstream, pH dependent, the enzyme via the miglustat, but itself miglustat is not doing. So the modeling for chaperones did not really work out well. So therefore, this was given away.
You showed the brain abnormalities in patients with IOPD. Nadine van der Beek also described a new phenotype in long-treated patients, that they also develop distal muscle weakness.
Yeah. So this distal muscle weakness is something very peculiar. We are not sure. So at the beginning, I was always saying, well, if it could be more a peripheral nerve involvement here. That was always, but the nerve conduction studies in all this infants. So we had a long discussion also with Peter van Dorn on this. He was also very much interested in this, and it did not turn out. And even if we looked at the biopsies and looked for the EMG and MRIs, so this story stays a bit unique. So it seems so that it is a very unusual glycogen storage in these distal muscles. It was described in a very few adults.
Yeah.
But there I have always a doubt if this is not an overlay with something else. So that could be a second disease. But this is absolutely unique to this infantile modified phenotype, that they have really this steppage gate on top, even if they're treated well. Even with high doses of the new enzymes and old enzymes, it stays like this. It's very peculiar. That's right.
Yeah, thank you. And I have a question about the neonatal screening. I don't know about Germany. Unfortunately, it has not been introduced in the neonatal screening program in the Netherlands. How about Germany?
Very similar. There's so far, to my knowledge, the only European country that is doing, and not nationally, but locally, is Italy. So Tuscany region, as one of the examples, is doing screening, but everyone else is discussing. We have a discussion ongoing in Germany, what we are doing with that. But honestly, we're looking at these outcomes of the infantile onsets. We all currently are a bit hesitating if that is really something we should really push very much forward. So we need more solutions. So if we have a good really gene therapy in place, so it's a different to the SMA field. So there you really prevent lives. You really do so good if you treat them very early. I still have some doubts if that is really the situation in Pompe disease. For the adults, yes, here I changed really my understanding. Here we need to start earlier. So what we had, so we need to have an update of this epoch guidance again. I think we need to start earlier, and there could be substrate reduction, could be a very nice situation that you first start with, reduce the total amount of glycogen, and then at the second step, you include the ERT, and perhaps then whatever type of things. I'm very curious what will happen if we have the enzyme linked to the transferrin receptor. If we then see new things, perhaps need much less amount of enzyme, because we need really super high amount of enzymes. So that's something else that could be really interesting. And it will start next year. So I think next year we will have the first phase 1/2 trials on this as well.
Wonderful. There are two questions by Suranyana Banik. The first one is, are the current treatment modules going to improve the neurological outcomes provided the current ERT can't pass, I think, the blood-brain barrier?
Yeah, in the adults, definitely. In the adults, we have improvement in patients seen, especially for the stabilization of the lung function, but also for proximal muscles. So there's always something. Of course, it's not 100% stable. It's a fluctuating disease. So that's something we also learned. The fatigue topic is more interbound than we thought in the beginning. So that's something important. So we need to keep that in mind, that sometimes it's not a new type of weakness. Could also be a fatigue topic that is included here. So therefore, that's important.
Yeah, and an example, or rather a question from the daily clinical practice. If a patient is diagnosed at age 55 years, would then ERT be an indication?
Yes. So if it's diagnosed as Pompe disease with a clear enzyme decline and also the GAA mutations, then definitely this would be a clear start signal if there's a clinic. If it's just a hyperglycemia and nothing else, you could wait and see. So that's something we always need to keep in mind. It's not a wonder drug. All of the three we have, they are good. We have a good safety profile as well. But of course, we need to consider what we are targeting here.
Yeah, I was intrigued by the targeted gene therapy targeting, for instance, on the liver, muscle, CNS. With regard to the latter, would that then be administration directly into the brain?
So that is one of the topics that was always discussed, that we do it like the antisense oligo treatments in SMA directly to the brain. So in the cerebrospinal fluid. So that is one of the options. But of course, if it's really for the infantile onset, you would do it systematically as well.
Yeah.
There's one element I did not mention that also can come up. Many of the adults, so it's the minority, have a so-called one of the very famous splice site mutations in the GA. And there's a new approach, really looking very similar like we have it in SMA, for going for an antisense that is skipping these mutations, so that we have a similar situation, because that would mean that for the adult patients, not for the infant, but for the adult, that we could normalize enzyme levels in a rather easy way. So that will also come up very soon. That's perhaps an option I haven't mentioned in the talk.
Yeah, lots of very exciting developments ahead of us. And my last question refers to, you mentioned palliative care in the patients, for instance, who are very severely affected to such an extent that they cannot be administered ERT, or the patients who stop having ERT. It would be very helpful if the EPOC would give some concrete recommendations, because you know as much as I do that advanced care planning or palliative care is rather unknown amongst doctors.
Yeah, I fully agree with that. But the good thing is, due to the ALS situation, I don't know about the Netherlands, but we have now really nationwide in Germany really this palliative care network. And there we start really to integrate also other neuromuscular diseases, because that's something we missed. And that's something, you know, that's close to our both hearts, because we see this always, that this is not happening. But this is really something we need to work on and to continue, because also this means a lot to the patients. And unfortunately to say, as this is a European reference network for neuromuscular disorders, but the last years of our patients, we hardly have knowledge.
That's right.
We don't know, because they stay at home, they have their caregivers, they have their nurses and their nurse teams and things like that. But as researchers, doctors, and scientists, we neglect this. And really putting an advanced care planning on top of this, that would also give us a chance to get a little more feedback and a little more learn about these late situations in the life of our patients.
Yeah, thank you so much. I think this is a very nice concluding comment. I would like to thank you once again. It was really a fantastic lecture, and I'm very glad that we could have the discussion afterwards with also input from the audience. Thank you so much, Benedikt.
Thank you.
Thank you very much. Goodbye.
Bye-bye.